So the topic for this discussion is congenitally corrected transposition. So here, as you see, superiorly and to the right, we have the morphologically right atrium. Coming into the morphologically right atrium is the superior caval vein. The inferior caval vein is coming in here. And there is the third channel that has been opened here, running around the left atrioventricular junction, the coronary sinus. So all the systemic venous return is coming into this morphologically right atrium, and here you can see that I'm pushing my finger through the flap valve of the oval foramen, and here on the right side you see the oval fossa. So we have all the features of the morphologically right atrium, but the key feature that tells us that this is the morphologically right atrium is beautifully seen when I open up the right atrioventricular junction, and you see how the pectinate muscles marking the right atrial appendage run all the way around the vestibule of this morphologically right atrioventricular valve. Now I say the morphologically right atrioventricular valve rather than the tricuspid valve, because as I open the right side of the heart, you can see what makes this congenitally corrected transposition. And that is the fact that this morphologically right atrium is connecting to a morphologically left ventricle, and it's doing so through a morphologically mitral valve. If you look at the structure of this valve, you see that it has one leaflet here that is relatively deep, and if I pass my probe beneath that valve, you see it goes out through the arterial trunk that is arising from this right-sided ventricle. And you can then see that the other leaflet of this valve is long and shallow compared to this leaflet, which is relatively short but deep, telling us that this is a right-sided mitral valve guarding the junction from this right atrium to the morphologically left ventricle. We can also tell that this is a morphologically left ventricle because of the fine crisscross nature of these apical trabeculations. So what we have here is a right atrium joining to a left ventricle, a discordant atrioventricular connection. And of course, in this particular heart, the morphologically left ventricle is on the right rather than the left side. If I show you the heart from behind, you see that here is the apex. So this is the right side, this is the left side, and this morphologically left ventricle is right-sided. Now the front of this heart has not been opened, but the other feature that tells us that this is congenitally corrected transposition is that when I push my forceps through the outflow tract of this left ventricle, and you see the outflow tract is relatively posterior relative to the ventricular mass. As I fold back the heart here, you can see that the tips of my forceps are emerging into an arterial trunk that is branching, an arterial trunk that is posterior to the aorta. Here is the aorta, and this arterial trunk arising from the morphologically left ventricle is the pulmonary trunk. So that the systemic venous return coming to the morphologically right atrium is being pumped to the lungs through the pulmonary trunk, despite the fact that it is going through the morphologically left ventricle. So now let's look at the other half of the heart, the left-sided half of the heart. And so if I open the left side of the heart from behind, you see that the atrial chamber is a morphologically left atrium. Coming into the roof, we have the pulmonary veins, although they've been cut away from the most part. the chamber is also dilated, and I'll show you the reason for that shortly. You see that at the front, through here, we have the opening of the appendage, the pectinate muscles confined within that appendage. When you look at the septal surface, you see the typical horns of the flap valve of the oval foramen, which is intact. So we have a typical morphologically left atrium that is left-sided. But then the left atrium is passing through a morphologically tricuspid valve, which has a septal leaflet, an inferior leaflet, and an anterosuperior leaflet, and it is joining into a coarsely trabeculated, morphologically right ventricle. So now you can see we have discordant atrioventricular connections. Not only is the right-sided connection discordant, right atrium to left ventricle, the left-sided connection is also discordant, the morphologically left atrium being connected through a morphologically tricuspid valve into the left-sided morphologically right ventricle. And when we look at this tricuspid valve, you can also see the reason why there is regurgitation across the valve, giving us a dilated left atrium. And that is because there is minimal displacement here of the septal leaflet, minimal Ebstein's malformation of this somewhat dysplastic morphologically tricuspid valve. And that is the reason why the valve is regurgitant. But if we complete our analysis of the atrioventricular connections and then the ventriculo-arterial connections, when I show you the anterior part of this left-sided morphologically right ventricle, you clearly see that the arterial trunk arising from the right ventricle is the aorta. I've opened the aorta through the non-adjacent aortic sinus, and there arising from the two sinuses that are adjacent to the pulmonary trunk, you see the orifices of the coronary arteries. This artery is supplying the morphologically right coronary artery, which then encircles the morphologically tricuspid valve, albeit on the left side. This other artery, arising from the more anterior of the sinuses, is then going to give rise to an anterior interventricular and a circumflex coronary artery, so the morphologically left coronary artery, albeit on the right side of the heart. So the aorta is taking its origin from the morphologically right ventricle, showing that we have not only discordant atrioventricular, but also discordant ventriculo-arterial connections. And it is the combination of the discordant connections at the atrioventricular junctions, together with those at the ventriculo-arterial junctions, that corrects the circulatory pattern, because the pulmonary venous return, coming in here to the left atrium, will be pumped to the body, but will be pumped to the body by the morphologically right ventricle rather than the morphologically left ventricle. And indeed, we know that it is part and parcel of the natural history of congenitally corrected transposition that it is the ability of this morphologically right ventricle to pump the systemic circulation for a lifetime that determines the prognosis of patients with this malformation. Double discordance, if you will, the combination of discordant atrioventricular and ventriculo-arterial connections congenitally correcting the pattern of circulation.